All right, a couple minutes past 11 o'clock here, everybody. Thank you for joining us here for this Medical Alley webinar presented by Genentech. So today's presentation is titled Cancer Care, a case study of how an employer manages benefits to improve outcomes. And with us today, we plan to have two experts joining us to highlight this current landscape in cancer care and to really stress the important role that employers play in designing benefits which encourage better access to oncology care. With us today is Josh Freund, who's a senior benefits manager with Genentech. Josh has been with Genentech now for 3 years and is currently pursuing his master's degree in public health. We also hope to have Dr. Abby Benyot with us. She is an associate professor of medicine with the University of Minnesota, an interventional pulmonologist and a practicing physician who is in the clinical setting here today. And we hope to have her joining us in just a moment to kind of set the stage for the entire hour of this webinar and what she is seeing really in cancer care and cancer screening. So a few logistical notes before we get started with everything here today. If you have a question for either Josh or for Dr. Benyot, we have a Q&A portion where you're able to add questions and then we can ask those to our experts. So put those into the Q&A function there on the side, really at any point throughout today's presentation, and we will do our very best to answer those questions toward the end of today's presentation. Also, another reminder here too, you notice in the upper left corner, the recording light is on. We are recording this webinar, so if you'd like to rewatch it, to hang on to any of this information, or better yet, to send it to a colleague, that is available to do so. So with that, I think we're going to get things started here with, oh, there's Dr. Benyot. Looks like she's joined the call. So we'll start here with Dr. Abby Benyot. Dr. Benyot, thank you for being with us today.
Hi, sorry to be a couple minutes late. You want me to go ahead and get started with my screen here?
That would be perfect.
Okie dokie. How's that look?
That's great.
Okay, great. So I'll give a little overview of, cancer burden in general and some perspectives on screening and early detection in cancer. So this slide shows the burden of cancer in 2023 in Minnesota and in the United States. It shows by, something on the bottom looks kind of funny, by site. Let's see here. So, excuse me, I don't know why that stuff's at the bottom there. Okay, I'll try to ignore that. So shows all sites here. The top section of numbers is what we call incidence or new diagnosis, new cases of cancer. And then the bottom section of numbers refers to deaths, or how we call mortality when we're talking about epidemiology and cancer numbers. So, thankfully you can see there are fewer deaths than incidents, fewer deaths than new cases of cancer in 2023. But certainly still quite a lot of people in the United States, 600,000 people died of cancer last year. And then each of these subtypes of cancer is broken down to give you an idea of how much each type of cancer contributes to that total. So for example, breast cancer is a huge contributor to the number of cancer cases. Prostate cancer is a huge contributor to the number of cancer cases. And lung cancer is a huge contributor to the number of cancer cases, more so than the other cancers. However, if you look at deaths, things are a little different there. So leukemia is a huge contributor to the number of deaths. Breast cancer is a much smaller relative contributor to the number of deaths than it is to the number of total cancer cases. So that reflects the fact that treatment for breast cancer is quite good. Non-Hodgkin's lymphoma, again, a huge contributor to deaths, but relatively smaller contributor. So this reflects some differences between different types of cancers, which I'll give you something of a brief overview too. Here is another way to look at some similar information, which is showing you on the top new cases or are incidence of cancer, and on the bottom, deaths from cancer. This one is broken down between men and women. So of course, prostate cancer is the leading cause of cancer in men. Breast cancer is the leading cause of cancer in women. However, for both men and women, the leading killer from cancer is actually lung cancer. Lung cancer kills more people than breast and colon and prostate cancer combined, and we'll talk a little bit more about that later. This looks at any type of cancer, an individual person's risk of developing cancer by age. So age is, of course, one of the greatest risk factors for developing cancer. So this gives you an idea of people that are working age, and as people get older, their chances of developing cancer. So all the way over here to the right, over someone's entire life, men have a 1 in 2 chance of developing cancer at some point in their lives. Women have a 1 in 3 chance of developing cancer at some point in their lives. So this is very common. This is going to affect many people very personally or someone close to them. Up until the age of 40, those chances of developing cancer are smaller, but they definitely start to increase to the 6th and 7th decade of life, again, towards the total lifespan. So when we talk about preventing cancer, we can describe cancer prevention in a few different ways. We can talk about primary prevention, which is risk reduction, so avoiding cancer altogether. That would look like minimizing exposure to known carcinogens, healthy lifestyle, maintaining a healthy weight, avoiding excess alcohol, avoiding tobacco, radon, pollution, other carcinogens that have been known and are now less common, asbestos, environmental pollutants, occupational pollutants. So anything that is known to cause cancer, reducing risk to those things would be considered primary prevention. Secondary prevention is what we're going to spend most of our time talking about today, at least what I'm going to talk about. And that might be considered early detection. So that's either screening for cancer or testing to detect cancer early. And there's a slight difference between screening and early detection, but the idea of secondary prevention is that the cancer is already there, but we're finding it early enough that we have a good chance of treating it. And so we're preventing some preventable consequences of the cancer. And then finally, tertiary prevention really relates more to recurrence of cancer. So this is people getting appropriate treatment and then appropriate surveillance after successful treatment of cancer to prevent the cancer from recurring. So screening can happen for not just cancer, any types of conditions, but in general, screening is in medicine a concept that we are aiming to look for a condition before it even causes symptoms, when it's easier to treat and when it's in its early stages. So screening is an important distinction in medicine and in epidemiology because it's one that's not always understood by an individual person that it affects or the general public. But the idea behind screening is that we're always thinking about large groups of people. So the screening tests that are recommended, the screening tests that are typically covered by insurance, are those that we know from large studies can, in a specific group of people, either all men, all women, all adults, all people over a certain age, all people with a certain risk factor, can find the cancer early, and that there's a test that will detect the cancer and that's safe enough and cost effective enough to conduct on everybody who meets those criteria. So the screening test, of course, has to reduce the chance that someone will die from the cancer. And we'll get into this a little bit more with some other cancer illustrations I'll show you. But screening is recommended primarily to save lives. And of course, the test and the screening has to have more benefits than harms. So if you've paid attention to even national news, there have been discussions over the years about breast cancer and prostate cancer, and should we screen and who should we screen? And this is really why those conversations change and why those recommendations change, because we're looking for a test that will find a cancer early, will save lives, and is going to benefit more people than potentially harm them. Screening tests can be harmful. Depending on the type of test, you can have an actual complication from the test. You can have a false test, either a false positive or a false negative. And so if you do a test that gives you the wrong answer, that really puts you in a worse place than when you started. And you can even have a harm that is characterized as overdiagnosis. Overdiagnosis would be a scenario where you diagnose a cancer that would never have led to a death, would never have led to a serious problem. This is probably the most difficult one to sort of wrap our heads around, but the idea that there might be a cancer which didn't need to be identified and didn't need to be treated. But of course, screening and early detection is really important. So I have a list of cancers here, and I've kind of highlighted some different colors to tell how they might differ. So this looks at the 5-year survival rate. So the chance of being alive, the number of people that are alive 5 years after diagnosis with specific types of cancer. So on the top left, we see breast cancer for women, and then it shows you the 5-year survival for all stages, and then we break those down by local, regional, or distant cancer. So early cancer, cancer that has spread somewhat in the area versus cancer that has widely spread. So for breast cancer, again, breast cancer treatments are good, even for people who have had widespread disease. So all comers, when you look at breast cancer, 91% of people with breast cancer who are diagnosed are still alive 5 years after diagnosis. Colon cancer, you see things are a little differently here. So if you look at local cancers, those are pretty good 5-year survival rates, but the numbers are drastically different if it's regional or distant. Lung cancer is the same way. So these green cancers are cancers for which there are recommended screening tests because early detection makes a big difference in survival. Some of these red tests over here, red cancers over here, are ones for which there are not recommended screening for sometimes a variety of reasons. For example, it might be that even if you detect it early, the treatments are so bad that it's almost uniformly deadly. So something like pancreatic cancer would fall under that category. So we don't have screening tests for pancreatic cancer because even when you detect it early, the treatments are not good enough. Ovarian cancer is a little bit of a different story. There's a big difference between an early detection and a late detection, but it happens infrequently enough that it just doesn't make sense to screen everybody. So this kind of gives you an idea of the complex interplay of each cancer and why we screen for it, or if we screen for it, has to do with what screening tests are available, as well as what treatments are available, and how many people die of this disease. So these are currently recommended screening tests for cancer. Breast cancer screening is recommended with mammography. For women over the age of 40 or over the age of 50, there's slightly different variations of evidence there. Other potential risk factors that might affect screening guidelines would be something like family history. Colorectal cancer screening is recommended. I'm going to talk a little bit more about this. There are several different tests, invasive tests or stool-based tests. And now screening for colorectal cancer is recommended for all adults over 40, regardless of any known or absence of any risk factors. Cervical cancer screening is recommended with pap smears or HPV tests for women generally of reproductive age. And then lung cancer screening is relatively new. This is recommended for people aged 50 to 80 who have had some smoking history. So not everybody 50 to 80 is recommended to be screened for lung cancer, but people who have a significant smoking history are recommended to get a CT scan every year for screening. These are some screening tests that are not routinely recommended, as I mentioned. So the United States Preventive Services Task Force is a non-governmental organization. They're an independent organization who grades the strength of evidence that's available. So clinical trials and research studies that have been done looking at screening tests and looking at these things we've talked about. How many people die from the disease without screening? How many people die from the disease with screening? What are the harms of the screening tests that are available? And so even though some of these can be very deadly, and probably you've heard of some of these cancers, pancreatic, ovarian cancers being very serious, screening is not routinely recommended because we don't quite understand who gets this. We don't understand what the risk factors are. So we can't screen everybody, even though they are very serious conditions. Something that's been more available a little bit recently are these multi-cancer detection tests. There are a few of these. Some of the folks in the audience may be very familiar with these, I'm guessing. I will summarize that in a way that just says this is a test that measures, biomarkers or biological signals. They're different types of ones, looking for DNA, looking for proteins that might be shed by cancer cells in the body. So multi-cancer detection tests, I think, are appealing and interesting to a lot of people because they were not screening for one type of cancer, but they're screening for a variety of different types of cancer. But no large-scale studies have been done to show that these are effective. that if we screen otherwise healthy people without symptoms with these tests, that they will in some way save lives on a large scale. None of these have been approved by the US FDA. There are some available. Healthcare providers can order them. So this is kind of maybe the next frontier of healthcare and of benefits, but still an area of a lot of gray, a lot of gray. So I'll share with you a few emerging trends in some of the most common cancers of what's been happening lately. In general, with breast cancer, mortality is declining, fewer people are dying, and incidence is slightly increasing. Again, this is a story of really good treatments available for breast cancer. So most people survive breast cancer who get it. Colorectal cancer, overall, incidence and mortality are declining. So fewer people are getting it, fewer people are dying of colorectal cancer. However, some recent disturbing trends have been identified over the last decade or so with increases of colorectal cancer in younger people, people who are lower than the age of 55. Right now, scientists do not know why this is happening. So one implication of this is a change in screening recommendations, which I'll get into a little bit more. Lung cancer incidence and mortality are declining, which is good news. Historically, lung cancer has been a very serious disease, nearly a death sentence, but through early detection, as well as improved treatments, we're really seeing an improve in the incidence and the mortality of lung cancer. In addition, we're seeing more people with lung cancer diagnosed at an early stage, which again is good news for treatment and survival. Liver cancer, so this is a cancer for which there's no screening test recommended at this time. There are some known risk factors for liver cancer, hepatitis, alcohol use. So incidence rates have tripled over the last 4 decades of liver cancer. Again, I don't know that reasons exactly are clear, maybe alcohol use, but it's not, I don't think it's definite. In the last few years, this is slowing, but we've definitely seen a huge spike in the last 40 years of liver cancer. And then pancreas cancer, there's been a slight increase in incidence and mortality recently. Again, treatments for pancreatic cancer are not that great. And so many people with pancreatic cancer ultimately die within 5 years. So here's an example of, I think, a success story, lung cancer, success in both early detection and treatment. So, of course, it's important to note that the primary cause of lung cancer is cigarette smoking, and those rates have declined as well. So lung cancer mortality and incidence numbers have definitely seen a multi-decade delay, but trends along with tobacco use. And so those have decreased as well. So that's good news. In the last 10 years, the rates of lung cancer have decreased by 1/3 for men, 1/4 for women. So that's great news. More people are presenting with an early stage, which is more treatable. And in addition, there's a lot more treatment options even for later stage. So this is a story, and of which there are many in cancer treatment, of targeted therapies or personalized medicine. So on the right side, this is a graph of a variety of different mutations. You know, these mutations are all combinations of letters and numbers and describe genetic alterations that can be targeted with treatment. So targeted therapies are not your traditional chemotherapy, which is just kill all the cells and hope some of the good ones survive. This targeted therapy can really be more effective and much better tolerated. So targeted therapies have been an important part of treatment for lung cancer and other cancers. But of course, these therapies come at quite a high cost at times. Colon cancer, as I promised, I would talk a little bit about that. So this is another example how screening recommendations change in response to disease trends. So over the last 20 or 30 years, colorectal cancer and all GI cancers have been rising steadily among adults younger than 50. Again, we don't understand why this is. Certainly people have theories, but studies have not been able to figure this out yet. So this year, nearly 18,000 people under the age of 50 will be diagnosed with colorectal cancer. This is really important because up until last year, 50 was the youngest age recommended for screening for colorectal cancer. Similar trends have been seen in Canada, New Zealand, Australia, and some other parts of Europe and Asia. So in response to this, there's been a recent change to screening guidelines for colon cancer. Now adults over 45 are recommended to be screened to identify these cases earlier and catch these before they become advanced. But The other important implication of this is that access to early detection services is important for people who don't meet established screening criteria. So they have symptoms, in this case, maybe blood in the stool. They need to have access to diagnostic testing to respond to these symptoms for early diagnosis. Cancer treatment options like personalized medicine and costs are growing quickly. So the majority of people with cancer and their survivors are unprepared for the cost of their cancer care. Many of them, really, the cost of their cancer care weighs heavily on them. This is a survey done by the American Cancer Society. And it's important to note that most of the people in this survey were employed and had health insurance and had more than median income. So this was not a group of primarily low income or uninsured people, but even people with health insurance who are employed can experience serious medical debt that affects their financial health and their ability to seek care in the future for other conditions. I found this one quote from the survey that I thought might be meaningful to this audience. And, this person describes how their treatment for their cancer was spread over 2 years. So they had to meet the annual deductible twice. And then during the second year, the employer changed insurance company. So they had another new deductible to meet for another new health plan. And then the insurance company decided what kind of expenses that they had to pay. So this person really struggled with getting their care because of implications of their health insurance. Working age people with cancer, people who are employed. The study specifically looked at people under the age of 65, mostly because then generally people go on Medicare, but testicular cancer, thyroid cancer, leukemia, uterine and ovarian are the most common cancers in people under the age of 65. And so you see the blue lines are the people under the age of 50, and the red are people ages 50 to 64. So one important thing to note is that for many of these, a screening test is not even recommended or currently available other than the uterine cervix cancer. So I think what I want to say in conclusion, of course, is an ounce of prevention is worth a pound of cure. Minimizing the risk of developing cancer through a healthy lifestyle and avoiding carcinogens is always our number one goal. But cancer is more treatable when detected early. So there are some cancers for which we screen, and there are some specific reasons why the ones that are recommended are chosen, and that saves lives. But there are other cancers that there's no screening available or no screening recommended. And so early detection is really key. So both awareness on the part of individuals and then access to healthcare that allows them to identify symptoms and promote early detection is really important. Cancer treatment is very expensive, and even people who are insured are financially impacted by that for a long time. And I think that's all I have. So I see some questions in the chat. Do you guys want to wait or?
Yeah, I think we'll do some Q&A toward the end here
Sure.
too.
Okay.
Dr. Benio, thank you for all of that really good information. Let's turn it over now to Josh with Genentech.
All right. Well, thank you. I really appreciate the opportunity to follow Dr. Benio's presentation, because what she did was help us set the stage for what I'm going to talk about for a few minutes, which is how do employers, or how have we as an employer thought about and responded to that national data around cancer prevalence, cancer screening guidelines, mortality, et cetera. The first couple of slides I'm going to run us through just give you an introduction to Genentech, and then we'll get into the meat and potatoes of the presentation. All right, so a little bit about Genentech. We really pride ourselves on developing innovative drugs and with a focus on personalized medicine. We've treated 16.4 million patients with 27 billion tests conducted. Genentech is a member of the Roche Group of companies. We have 100,000 or so employees in over 100 countries. We have done a significant amount of investing in oncology and trying to innovate and push this area forward. We've got $15 billion invested in R&D with more than 5 million patients treated by Genentech medications since 1997. We continue to push forward on the frontiers of treating oncology with investigational medicines. We've got many different tumor types that are treated by our medications. So as you can see, the company itself is very, very much dedicated to understanding and treating cancer in the population. And I'll talk a little bit in a second about how that informed our own process of thinking about treating cancer in our employee population, who we in the benefits team at least consider our own patients. We are trying to improve the patient experience, integrate drug development, realize the potential of personalized healthcare, and bring new therapies to market, among other things. I think one very important factor here is the recognition that many different people were not included in clinical trials historically, and a big part of our mission is to ensure that clinical trials are represented by everybody, so that we are treating all patients with our medications and everybody has the opportunity to benefit from them. Again, this is something that really has informed a lot of the way we're thinking about cancer in our own employee population. We have this commitment to cancer care health equity. As you can see, we've got a partnership with the American Cancer Society, along with the X Project, which is really focusing on women's health and driving health equity and inclusion for women's cancer, which is of particular importance to us, especially because breast cancer is the leading diagnosis of cancer on our health plans. So it's an area of focus, again, both for the company and for our benefits team, as we're thinking about different strategies to employ to treat cancer in our workforce. So our approach from a benefits perspective really focuses on three key areas: prevention and screening, diagnosis and treatment. Okay, well, that's all of cancer, right? And what I'm going to go through in a couple of slides is how we've thought about each of these, and what are some of the steps that we've taken to ensure that we're getting all of this as right as can possibly be done for an employer. There are definitely some challenges to it, but I think what we've demonstrated, at least in our own population, is a fair amount of success, particularly in the prevention and screening side. So the data that you're seeing on the screen now is new breast cancer diagnoses in our population. This is actually 2022 data. In 2023, we're seeing very similar data. And what I want to call out here is, from an employer perspective, the cost of providing all healthcare is finite. And I think if there are any other benefits managers that are listening on the call right now, you know the kinds of conversations that we have to go through to make sure that we're providing the best possible healthcare to our employees, but at a reasonable cost to the company. And that's one of the reasons it's so important from our perspective to get people diagnosed with cancer as early as possible. In our most recent data for 2023, the average cost of a stage 1 cancer diagnosis across all cancer types is $18,000. The average cost of treating a cancer at a stage 4 diagnosis is $273,000. Now, I'm very happy to say that in 2023, 96% of all of the cancer diagnoses that we had on our health plan were caught at stage 1 or stage 2 diagnosis. So much, much less costly to treat. And as Dr. Benyot demonstrated in her presentation, it also increases the rates of survival or reduces the mortality of the cancer diagnosis. So not only is there the financial incentive, but we're really trying to ensure that people are getting that cancer diagnosis at a stage when it can be treated and which they will survive, recover, and hopefully thrive in their lives. So how have we incentivized preventive care and screening? Well, in 2020, we started rewarding our employees. We actually have a wellness program, and through our wellness vendor, we are incentivizing screening and early detection in our population. We pay people $125 to go get their physical. If you get a cancer screening, you get another $100. So in other words, we have put this financial incentive in place to ensure that people have at least a financial incentive to go and get their screenings. Now, before I move on, and I think I have this in another slide, but I want to say it now instead. One of the things that we've done with our screening is we've removed all of the age guidelines associated with screening. So whether you're 20 years old or 50 years old, if you have a family history, for instance, of breast cancer, or if you have some suspicions of breast cancer, or if you are just frankly a little bit fearful for some reason that only you know about, you can go get screened for breast cancer. So we've removed any of those age gating programs that kind of exist in health plans. And up on the screen now is an example of why we have done that. So the incentives motivated one of our employees to go get the screening for breast cancer. And within a week, she was diagnosed with breast cancer. So from our perspective, something as small as a financial incentive was really life-changing and frankly saving in a person's experience. Now, this is anecdotal, but what we see in our data, and I'll repeat what I said a few minutes ago, what we see in our data is these incentives really are driving a very high level of engagement in breast cancer screening, colorectal cancer screening, et cetera. And generally, we are getting people into their diagnosis at very, very early stages. We also have return to care campaigns. So we've had a really big focus on sending out emails, and particularly after the pandemic when people were still returning to care. We've used integrations with our business. We've used existing awareness months. We've sent this out in an omni-channel way. In other words, we're communicating with our employees constantly about the value and the need to get early detection and screening. And we continue to do this in more and more targeted fashions. I'll talk about that in just a little bit. So what happened with our targeted campaign that we started running out in 2021? We've got increased awareness. We've got a big increase in our rally registrations. So we sent out this email communication. We sent home postcards. And in doing that, we were trying to drive as participation in rally primarily, where they would see early cancer diagnosis, where our employees would see early cancer diagnosis options and be able to take advantage of them. And I will say in 2023, as our efforts have continued in the communication side of things, we've seen increases. Now, at this point, they're nominal increases because we've got a very high screening rates for all of our screenable cancers. So where we're seeing increases, we're feeling this is a positive trend. For instance, in breast cancer alone, our screening rate across our entire population is around 83% for 2023. So again, we hold ourselves to a very high standard, not just because Genentech as a business is in the business of treating cancer and developing new medicines for cancer, but because as an employer, we want it to be aligned with the business and we want to make sure that we're providing the best possible healthcare for our employees. And one of the things that I want to really call out here is sometimes the best possible thing for your employees is not the newest, most innovative thing. I think a lot of times when I've given this kind of presentation or when I talk about what Genentech has done in the past, people are a little bit surprised that the innovative thing or the thing that we're talking about is really just making sure that people are getting, for instance, their breast cancer screenings. But over and over, we have been validated by the data, and it suggests that this isn't necessarily a place right now where the newest technology is going to solve the problem for you as an employer. What's going to solve the problem for you is thinking about how to get as many of the people as you can who are eligible for breast cancer screening, who need breast cancer screening. And I keep harping on that because, again, breast cancer screening represents about, or breast cancer represents about 60 to 70% of our new cancer cases. So it is a huge focus for us. And as you can see, our screening rates are relatively high. Okay, I want to shift gears a little bit and talk about this from a health equity perspective, which is where our focus has started to really go a little bit deeper. So even though I say our screening rates for cancers are relatively high, the truth is as an employer, you really have to dig into those numbers just a little bit to understand where you might have some challenges, right? There are some populations who maybe don't trust the healthcare system, or there are some populations for whom their work environment or their type of work doesn't necessarily allow them the opportunity to go get screened, right? Like that is a privilege that not everybody has. And so we started looking at breast cancer screening and annual wellness exams, but breaking those down by different demographic categories so we could understand where some of those differences were. And you can see, and we have continued to see this, it's a continuing ongoing challenge for us, the greatest disparities in screening rates for our population are not between our Black employees and our white employees. They're between our exempt employees and non-exempt employees. Now at Genentech, what that means, we have a lot of non-exempt employees who are working on manufacturing lines, who are working in shift work type jobs. And we're trying to find novel ways to bring screening to them so that they can benefit from the same level of screening benefits that we're providing everybody else. So that is our big challenge for 2024 going forward, is ensuring that our entire workforce has opportunities to get the screenings that we believe will help them and prevent severe cancer in the population. And you can see our screening rates by colon, cervical, breast, and annual preventive exams. Again, in 2023, all of these numbers have increased, which is a reflection of our ongoing efforts in communication and engagement with targeted communications to targeted populations. Echoing what Dr. Benyot has talked about a little bit, lung cancer is the leading cause of cancer death and has the lowest screening rate. That's true in our population as well. To those employers in the room, I will share, if this is something that's been on your radar, a little bit of frustration. It's a very difficult cancer to screen for an employer. We are working on ways to understand what our actual cancer screening rates are. Fortunately, in our own data, we have not seen a large number of lung cancer diagnoses in the last couple of years. But this is an ongoing challenge for us. And it kind of leads into the discussion of, well, if we can't do something in the screening, what can we do in the actual diagnosis? How can we help a patient who's gotten their diagnosis get the best care possible? So first, as I mentioned earlier, we've taken every effort we can to remove barriers to getting screened, and we continue to work on that. We worked on that first in plan design. Now we're working on that in communications. We're working with different business units to ensure employees can take the time they need to go get screened. We also want to make sure that people are getting a full diagnostic workup. Like I mentioned a few minutes ago, we have no age restrictions for cervical, colorectal, or prostate cancer screenings. Breast ultrasounds are covered as preventive care. You can kind of see the list here. We cover genomic testing. So we've kind of taken all of the approaches that we think we need to ensure that if somebody is getting a diagnosis for breast cancer, they've got everything they need. Again, I speak a lot to the benefit managers in the room. I think anybody who's not a benefit manager benefits from hearing some of this. So I'll sort of call it out. You know, as a benefit manager, I can't tell you the number of times over the years before working at Genentech, I will say, where we'd get a call from, you know, a woman who had gone to get her mammogram. The doctor had said, well, hey, you know, we think there's something here that means you should probably get screened more regularly, or you should get this different type of screening, and it's not covered by the health plan. Well, that's a disincentive for somebody, especially a financial disincentive for somebody who is at higher risk for breast cancer diagnosis to actually go back and get those screenings. We don't want those financial barriers to exist. And so we've done some plan design changing, as you can see here, to ensure that if, for instance, in a case like that, somebody is at higher risk of a type of cancer, they're able to go and get the genomic testing they need to sort of confirm that risk and et cetera. So we want to make sure that any other tests that might not be covered under a normal health plan are covered under ours. We've also partnered with Access Hope. So Access Hope reviews all of our cancer diagnoses remotely. So any medical record with a cancer diagnosis goes to Access Hope for a holistic look at the diagnosis and treatment plan. They'll provide a written review. If there are any clinical trials that might be available for that cancer diagnosis, they'll let the employee and their provider know. And this is about peer-to-peer collaboration. So essentially what Access Hope is doing for us is taking their wealth of knowledge and expertise and working with our patients and with their oncology providers, wherever they happen to be, to ensure that our employees are getting the absolute best diagnosis and treatment possible. We want personalized health care to be at the cornerstone of any future advancements that we see in the treatment of cancer in our population. So what that means is, and I alluded to this, when we work with Access Hope, we are trying to ensure that our employees, if there's a clinical trial happening or a new novel treatment happening, we want our employees to have access to those novel treatments or treatment modalities. We also have hired dedicated oncology nurses that will help work with our employees who have been diagnosed with cancer and work with them side by side on that cancer journey to help them understand not just the diagnosis and the treatment, but to help them understand any ongoing needs and that sort of thing. So we've really tried to help our employees who are cancer patients work through the system, which can be very complex when you're receiving cancer care. We've also got a dedicated health team, which so that the oncology nurses we have on staff are a part of the dedicated health team. They work with mental health clinicians who are part of that health team and other advocates to help make sure that people are navigated through the system appropriately. That includes a cancer care guide. We offer mental health support for cancer patients, up to 25 sessions per year per member of the family. 100% paid short-term disability program, paid caregiver leave, and actually in the second half of this year, we'll be rolling out an additional caregiver service. So if you are a patient of a Genentech employee who is diagnosed with cancer, or if you have a family member diagnosed with cancer, we have some additional caregiver support resources that we're going to be rolling out in the last half of the year. Things like financial counseling, help finding daycare providers in your area if you have to travel for cancer care, emotional counseling, all sorts of additional services being provided. So that's rolling out in the second half of the year. I'm going to talk a little bit about cancer and where we've been and where it's going. What we have the benefit of when it comes to cancer is the complete support and buy-in of our leadership. Now, I think that would be obvious. Genentech treats cancer. We have a number of drugs that are in the cancer space. And so our senior leaders understand the value to us of focusing on cancer. But if you don't benefit from that focus from the leadership immediately, I mean, one area that you might think about are, for instance, the financial costs that I mentioned earlier. Senior leadership is almost sure to support you in trying to address cancer in your workforce, if not for the quality of life for the employees, if not for ensuring the employees can lead productive, healthy lives where they can continue to be at the company, but also because, at least in our plan, we spent almost $40 million last year in cancer diagnosis and treatment in our population. It is not an insignificant amount of money for an employer to be spending to treat their population. So when you're thinking about that, you can think about it from the financial perspective as well. And remember what I said earlier, our average cost of treating cancer at stage 1 or stage 2 is around $20,000. At stage 4, it's $273,000 on average in our 2023 data. Well, we spent $40 million last year on cancer. Think about what it's like if you move that percentage of people diagnosed at stage 1, stage 2 over to stage 3 or stage 4. If you move just a couple percentage points, you're spending a lot more money in cancer. So there's really a financial incentive, frankly, from the fiduciary plan ownership side to try and get your employees screened and diagnosed in stages 1 and 2, if you can, and obviously stage 1 preferable. So that means promoting your annual wellness exams. I mean, this is the basic blocking and tackling of managing a benefit plan. And I know I tend to be the type of person who wants the newest, greatest, most inventive thing. But the truth is there are some things we don't need to reinvent. We need to make sure that people are getting their annual screenings, their annual wellness exams. We really do promote the importance of lung cancer screening. We have a relatively low risk population with respect to lung cancer, but we are trying to communicate to those areas where we think there is increased risk and get them some screening options in front of them. Like I've said, program design, genomic testing, cancer screenings are paid at 100%. We offer palliative care, which I don't think I mentioned before. We have paid time off for clinical trials, paid short-term disability at 100%. One additional note that I didn't mention earlier is the cryopreservation of sperm or eggs. If you're undergoing a cancer treatment, taking away that sort of stress for anybody who's hoping to build a family. We've got very robust oncology care management programs. We include travel and lodging accommodations. So essentially what we're saying here is, again, it doesn't take the newest technology. What it takes is looking at the course of treatment and prevention, diagnosis, and treatment of cancer, and thinking about what it's like to be a cancer patient and putting the right programs in place around it to make navigating that cancer treatment as easy as possible, and ensuring that you're receiving the highest quality care. I mentioned this before, it's a little bit of rehash, so I'm going to go really quickly. Incentivize good activities that you want to see in your health plan. We would urge most employers, not all, I suppose, but if you were trying to address cancer in your workplace, we would urge employers to look at incentivizing the right activities. It is a good investment for you. If you've got weeks or months that you've already built into communications campaigns, leverage the cancer campaigns, screening weeks, breast cancer month, also all of these areas that you can leverage, use those for communication. People will pay attention. Do whatever you can to remove barriers to screening. Get rid of the barriers, and you will see more of your cancer diagnoses go from stage 3, stage 4 to stage 1, stage 2. Try to create a personalized care and access profile for your employees. Most health plans, certainly on the self-funded side, will find people to operate as care navigators with specific expertise in oncology care. So if you can find that resource, you should add it to your plan. And then when you get a cancer diagnosis, the last thing you want to worry about is whether or not you can take off the time that you need to go get your cancer treatment. So we have taken this approach of looking at what does the time off look like, and can we build in some time off that's sensitive to a cancer diagnosis? I think I know there were a number of questions that came in during Dr. Benyot's presentation, so I'll stop presenting and open it up for questions.
Gosh, thank you. And Dr. Benyot, I want to thank you as well, too. It looks like you've jumped in and answered quite a few of those in the Q&A section. So I appreciate you being so tech savvy and able to provide those resources, too. So if anybody watching was looking at some of the questions and wondered where they went, there are 7 answered questions in the Q&A section with some really good information, too. So Dr. Benyot, thank you for that. Some questions that are left here in the Q&A, though. One from Kristen asks, are employees taxed on those reimbursements for those screenings, or is it done as a gift card option only?
So we have, our screenings are paid at 100% as preventive care screenings. So they're just paid through the plan. We did, as I'm sure your question is sort of alluding to, the taxability of the benefit and whether or not we felt that the benefit was taxable. We ran this through our own counsel, and it's a gray area. I mean, if you wanted to cover cancer screenings as preventive, you're taking on a little bit of risk, frankly, in the taxability issue, but we have not found that risk to be more substantial than the benefit of ensuring that everybody has access to cancer screenings.
Thank you, Josh. Another question here that just came in here too from John, and this probably is for Dr. Benyot. On lung cancer, how sensitive is the LDCT screening, and can it reliably detect stage 1 cancer?
Yes, I don't know who John is, but I can see that John has figured out he's tapped into my nerd zone and he's just going to go as deep as he can with questions. I love it. Very sensitive. Yeah. So someone else asked about a chest x-ray. Is that a next best thing? And unfortunately, the answer is no, because a chest x-ray is much less sensitive than a CT scan of the chest. So by the time something shows up on a chest x-ray, it may not even really be early stage anymore. It has to be bigger for you to see it on a chest x-ray. But a CT scan, very sensitive, does not pick up everything, of course, because CT scans are recommended every year for people who've smoked. And so certainly some cancers can grow faster than that. But I mean, we've detected cancers, at the size of 4 or 5 millimeters. And so it's very sensitive for early stage cancer, which is really what we want. I really want to echo some of the things that you said, Josh. I totally agree. And that is about this multi-cancer detection test. The newest, most innovative thing is not really where you want to be putting your money. I mean, this screening is public health, and public health is thinking about large numbers of people, and you get the most benefit from doing the most efficient thing, really, which in many cases is not the newest thing. And so that's why, I'll kind of wrap in the multi-cancer detection test as well as a better screening test for lung cancer. So multi-cancer detection tests, they may be the future, right? But right now they haven't been tested in such a way that we can say, oh yeah, these tests really save lives. Because when you do this, what we're looking for is a test that someone who is healthy and has no symptoms, they get their test, right? Maybe their employer has incentivized it, as you guys are talking about. So they get their test, they have an abnormal finding. Oh, I had no idea something was wrong with me. They undergo the next evaluation. Oh, we found a stage 1 cancer. We took it out. You're ready to move on and live your life like normal. And they get to have a full lifespan. And that's like the best case scenario. But a lot of other things can go wrong with screening. And so like a multi-cancer detection test, you can have a false positive. A multi-cancer detection test doesn't tell you necessarily where the cancer is supposed to be. So then you might be going down a rabbit hole of a lot of different potential evaluations to look into this possible, positive. So that is a lot of extra costs and potentially a lot of extra stress or complications from procedures. So they may well be the future. Right now, my big hesitation about multi-cancer detection tests is that they're really only available to people with a certain threshold of assets, access, and awareness. And so I'm really worried that multi-cancer detection tests are going to worsen health disparities for people who don't have access, don't know about them, and can't afford to pay for them out of pocket sometimes or deal with everything that goes along with them. I'll just quickly answer, what does a better screening test mean? That really depends on the cancer. So right now for lung cancer screening, it's a CT scan of the chest. So it's a good test. It identifies a lot of cancers, but it's not a good test to do to everybody because it gives you radiation and it has a lot of false positives, like lung nodules that are spots that have been there forever and they're not really a cancer. Then we have to evaluate them. So the best test leads to no false positives, no false negatives, minimal discomfort, minimal risk for the person. There are some breath tests underway, which will certainly not give you radiation, but will probably still have false positives and negatives. Those are just given things about screening tests. But I also loved what you said about incentivizing behaviors that you want to see, right? Whether that's smoking cessation. I mean, radon testing, okay, we're talking about lung cancer and people who never smoked. Radon is the second leading cause of lung cancer behind cigarette smoking. Pollution is well identified as a cause of lung cancer. I mean, so if you really wanted to get innovative, you could get innovative in incentivizing the types of behaviors that you want to see that will reduce the burden of cancer entirely.
Dr. Benio, thank you. Just a couple of minutes left here. I think there's one other question in the chat, and I think this would be more for Josh. The question is, do you have a TPA, which I'm assuming means third-party administrator? What role do they play, and how do you manage potential duplication?
Yeah, so we do have, we're a self-funded health plan. In the United States, we've got 23,000 or so employees enrolled on our plan, about 46,000 covered lives, which includes their family members, dependents, children, and spouses. And we have contracted with United Health Group to manage our health plan. So they do the adjudication of claims. Now, I said that we had this dedicated health team. The dedicated health team, we have worked with United Health Group to put that dedicated health team together. So They are the administrator. They are also the care navigation support. And from our perspective, it was just important especially when you're looking at something like oncology. I mean, the reality is that the healthcare system is incredibly complex, and a cancer diagnosis, even a relatively, I don't want to call any cancer a simple diagnosis, but for something like breast cancer, where the treatment protocols, especially if you're in stage 1, stage 2, are relatively stable, predictable, etc. Even in that scenario, navigating the healthcare system and navigating your cancer diagnosis is very tricky. So we felt that having a team that was sort of integrated with the health plan, knew the ins and outs of managing not just the health plan and the sort of insurance part of it, but also the oncology part of it, and understanding like where your treatment is going was really valuable. That could be debatable. I mean, for benefits managers now, there are the wealth of options for care navigation services. We felt an integrated program would be better, but we could be challenged on that.
Well, I think we're just at about 12 o'clock here today. So I want to close it there and to say thank you to Dr. Abby Benyot with the U of M and to Josh Freund with Genentech. Some incredible information too. And for everybody who is watching, a reminder that we will be sending out a link to this webinar. So if you'd like to rewatch anything or to take some notes or to send to a colleague, we would invite you to do that. So once again, thank you all for being here. Thank you to our panelists, and have a wonderful rest of your day.